In this breakdown, I'm going to be covering a very common cause of numbness, aching, burning, and tension in the neck and the upper trap, and accessory nerve entrapment. What's up, everybody? For those of you that don't know me, my name is Dr. Matt Maggio. I am the creator of the 𝐓𝐡𝐞 method and founder of the soft tissue revolution, where we teach self-employed massage therapists a new treatment system that focuses on working smarter, not harder, allowing them to cut their treatment times by 50% so they can stay healthy and help more people get out of pain. Nerve entrapments are a really big deal, and a lot of practitioners out there completely miss them, and it gets misdiagnosed, and if you can't find a problem, you don't know if you can actually fix it. So you got to figure out that these nerve entrapments are happening. So what I want to include first in this week's video is from one of our CEU courses, really going through what a nerve entrapment looks like in the neck, what it presents with, what causes it, and the different types of symptoms that you will see, so you know exactly what the problem is so you can eventually go in there and fix it.
Next one is nerve. I say this all the time. There are 256 different places in the human body where a nerve entrapment can occur. And there's a few in the neck that are really important that people miss. So basically, nerve entrapments in a nutshell, basically over time, as the muscle gets more beat up, it doesn't get enough blood flow, it doesn't get enough oxygen, it starts to develop scar tissue. Scar tissue is like glue, gets inside the muscle, makes it harder for the muscle to stretch and contract. I'm going to cover scar tissue on the next slide. But basically over time is that scar tissue gets bigger and bigger and creates like a space occupying lesion. And nerves need to kind of make their way through the body to go where they need to go. And they get stuck inside there. And nerves are built with like 15% of extra slack. So it beats them up a little bit more. So over time, these nerve entrapments occur. And basically where they get the type of problem, you can see that as well, especially in the cervical spine. They might feel like their trap is always tight. They might get some like pain in the anterior part of the neck and even some stuff radiating down in the shoulder blade. And then I also see some stuff like high up in the neck as well. Usually the symptom quality is going to really define that for me. It's going to be numbness, aching, burning, and tension. Provocative. A lot of times when you're having nerve entrapment, it's fine when you're just kind of sitting there, but as soon as you start to use it, it stretches and pulls that nerve and can really give you some pain and increase that numbness, aching, and burning and tension. Palliative just feels better when you don't use it or with rest. So 3 common areas to get nerve entrapments in the neck. One is going to be on the scalenes, specifically at the nerve roots at the scalenes from C5 to T1. The most common area where I see in a nerve entrapment on that is between the middle and the posterior scalene. The other area is going to be at the accessory nerve. That's a really common one. So the accessory nerve comes out behind the ear and then makes its way down, and it controls the SCM in the front and then the trap in the back, and it gets stuck in there. That's actually the most common area where people describe it as like they have a giant knot in their area, in their neck. That's usually an accessory nerve entrapment. And then the last one is just the greater occipital nerve. I see this a lot in the upper suboccipital group, specifically like rectus capitis major and minor, and a little bit of like semispinalis capitis and cervicis, and even a little bit of splenius capitis. The greater occipital nerves can get entrapped up in there. And that can really present with a lot of like your headache and migraine type of clients. But nerve entrapments are definitely a big problem in neck pain, and it's getting overlooked and missed by most practitioners.
The thing about my method, the 𝐓𝐡𝐞 method, really focuses on collecting data, slowing down and interpreting the data so we can know exactly what's wrong. And that's what you see in that first video. I'm really interpreting the symptoms. What are they telling me? Where is the problem? So I can form a tissue specific problem list. Then I'll be able to go in there and do some tests. I'll be able to do some palpation and then do effective treatment. Now, based off of those history questions, which I shared in that video, you're suspecting that there could potentially be a nerve entrapment. The symptom location, the quality, things that make it better, things that make it worse, their posture, everything they do. Now you're thinking that there can be a nerve entrapment in there. So the next thing we need to do is we actually have to go in there and palpate and find that. So what I want to link up next is a very detailed palpation of an accessory nerve entrapment for you to practice and learn from.
So the third test we had talked about was that cervical thoracic spine area flexion test where they drop their head down through there. So there's a couple things that can really limit that. One that everyone completely forgets about is actually an accessory nerve entrapment. Usually it comes out, it can get caught in here through the levator, it can get caught through anywhere in the erector group, the rhomboid, everywhere like that. So I like to get in there and palpate that, because if the nerve is getting stuck when patients go to move,
everything tightens up and it protects. So if you can get the nerve right and find where it's getting caught, it can make big changes in that overall range of motion. So what I do first is I have the patient hold their arms just like that. What that does is it allows that shoulder blade to get out of the way. Then we get in there and drop the head down. So I'm gonna have you come up a little bit more and really get in here. So essentially, we look for our landmarks here. So we find the superior angle of the shoulder and go through here. Where that nerve lives is in through here. So I get in here and I do compressive palpation, really trying to feel where that nerve is jammed up. And it's gonna kick right out when it is jammed up with that scar tissue. The patient would even jump just like she did. Now, the thing is, it gets stuck right in through there. And that's where that scar tissue is. And the thing about the nerve is it's very superficial. It doesn't need a lot of compression, and too many people are way too compressive with it, and it causes problems. The next thing you have to account for is the curve in the thoracic spine. So if you just go straight in, you're gonna crush it. You almost wanna come in at a 45-degree angle as you get in there and palpate, and that'll really open that up.
Now we're building up the steps. We know that problem was potentially there. Now we just backed it up with palpation. Now we have to get in there and actually fix it. In order to fix it, you need to get proper depth, then tension. A lot of practitioners end up being way too compressive in this area, and they end up crushing the nerve. It hurts like hell, but it doesn't do a whole lot of anything and actually makes the problem worse. So the last video we're gonna link up is a detailed treatment demonstration using my methods, the 𝐓𝐡𝐞 method, using specifically manual scar tissue treatment. I'm gonna link that one up right now too.
Just kind of run my thumb over, and when it's caught, it'll feel like a piece of string that's caught, and hers is caught right there. What do you feel in there, Joy? Some tension?
Yeah.
So now I found it and I know where it is. And the key here, if the entrapment is occurring right here, what you want to do is actually go just superior to it, because what we're going to be doing is called internal slide, where we set it and then the client goes through a range of motion and it forces it to go there. So once I find it, I don't really leave my thumb off of it, because then I know I'm there and I won't leave it off of there. Now the key is going to be the setup. So you're going to tell the client how you want them to move. She's going to start back in some extension. And then I'm going to have you drop your head down nice and slow, just like that. And they're going to drop it towards their chest. So what I'm going to do now is I'm going to bring it back in extension. Now the setup here is really key. So I have my thumb here just like that. And what I do is I come in at a 90-degree angle. So I'm facing opposite to the wall. Some people go like this, that's not good, or they're here. And all you're going to do is bleed out some force in there. So what I'm going to do here is the scar tissue's here. I'm going to be just above that. And the first thing I'm going to do, I'm going to come in at 90, and you see how my elbow gets nice and high. This is going to allow me to accommodate for that 45-degree angle in there. Next thing I'm going to do is I'm going to take my other hand, and specifically like the piezoform and the web here, and that's going to go in and basically cover up that thumb and protect that. So I'm here, and I'm in a really good position. And see how everything's lined up, and this kind of gets that line of drive as we go in there. In order, first we got to get depth on it, and my depth is going to be just a very slight lean with my hips in there. And if you're pushing too far, the client will move too much. You don't want that. It should just be enough where you're going in very gentle like that. Then the next thing I'm going to do is I'm going to drop my elbow just a little bit, just like that, and I'm going to kind of pull it in towards my body a bit, and then I'm going to drop a little bit more in a squat. And that's really loaded up. Now the client's ready for me to go through the motion, and go ahead. And I'm just feeling it pull, 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 pull. And as I'm getting more tension, I'm kind of leaning away with my body and down and pulling with that elbow. All of my force is coming through my thumb, but I'm keeping my depth with this other hand. So what I'll do is I'm gonna remove my palm so you can just see it with the thumb, so you can kind of see what it looks more like. So as I'm in there, I get my depth like that, and then my tension is like that. So the tension is a very short set. You want to actually get some tension into the nerve itself, and then it's loaded up, and then the client goes through that motion. So I'll set it up one more time. So we took the time to palpate it, always palpate it and find it. Never be directly on it, you want to be right up against it. So I'm here and I found it. I'm here, coming at 90. This one comes in and backs it up, and I'm not in a hurry. I'm staying here and I'm very controlled. And the first step, get my depth with that slight body lean, tuck my elbow in, and then I'm gonna do a slight squat to start, and I'm gonna wait a second, and that's loaded, and now I'm gonna have the client go through the motion. And I'm just feeling that pull, and as it gets more, I can get more tension by dropping that elbow a little bit more. And this area is pretty sensitive, so I usually get about 5 to 7 passes on it and then leave it alone. And a lot of times you gotta watch the client when they're going through stuff. Sometimes they'll drop their head too fast, sometimes they'll go too slow. So you wanna make sure you coach them in the right way. But the take homes here are accommodate for the overall curve of the spine. Don't be too compressive, because the nerve is right on the surface, and if you hammer on it and you pull on it, it might hurt like hell, and the client's like, oh, you're doing something. You're not. You're actually causing more damage in there as well. So the key is in your setup, palpating, finding it, and then getting in there and releasing that. So that's the accessory nerve treatment.
Take homes from the video. Number one is getting proper depth, then tension. Most people are way too compressive in this area, and they beat the hell out of it. They drop an elbow in there. They just really jam on that nerve, and it doesn't do anything except create a little bit of tension and a lot of pain. You got to get the proper depth and tension, using your body positions, using the types of mechanics that really are going to get you better leverage, and being able to drop that elbow in, lining your body up and putting yourself in a really good position. This is where that whole idea of working smarter, not harder, really comes in. And once again, just continuing to understand the importance of thinking critically, slowing down, then treating. You know, so many soft tissue practitioners just want to jump right into treatment, and they do what I call winging it, where they just try a bunch of stuff and never know what's really happening. You need a system, you need a process from start to finish, asking the right questions, thinking critically, backing it up with palpation, then doing results-driven treatment that has proper depth, then tension to remove that scar tissue getting stuck to that nerve and getting long-lasting results that last and keep the pain away for longer than anything else out there. So I appreciate you guys watching the video. If you like the video, share it with somebody, tag somebody in there that you know can help. Go grab our free training. I really go into the critical thinking aspects of things, showing some treatment demonstrations as well, palpation, critical thinking, finding and fixing problems, and getting you on the path to becoming a solutions provider instead of a service provider. We also have all our courses available online and in person for CEU courses, and really focus on the idea of being a clinician first, then a technician. Appreciate you guys watching the video, and we'll see you on the next one. Bye.